Welcome to the Polestar Rehabilitation Case Study from the S6R6 manual found on page 194. We have a 28-year-old female with a diagnosis of right lumbosacral strain. She is occupied as a stable hand and competitive equestrian rider. Subjective findings: primary complaint, acute right low back pain with sitting, with standing, and with walking, and stiffness with sit to stand. She's also unable to ride a horse. So as we go through the NAGI grid, filling out the problems and categorizing them into impairments, activity limitations, and participation restrictions, we'll take each piece of information from the subjective and objective findings and place them into the grid in the appropriate location. First, we have acute right low back pain with sitting. And that will go on the grid under activity limitations because the pain is described with or related to an activity. So we'll put here acute low back pain with sitting, also with standing, and with walking. This already sounds like a pretty significant problem. She also has stiffness with sit to stand, and that will also go into our activity limitations. And she is unable to ride a horse. Now that has an impact into her participation restrictions because this is a recreational activity. So she is unable to compete as an equestrian rider because she's unable to ride her horse at this time. Under description of symptoms, we see that she has right constant lumbosacral pain radiating into the right posterior buttock. So that is not related to an activity. So we're going to put that under impairments. Right constant lumbosacral pain radiating into right buttock. All right. Intermittent sharp twinges at the sacroiliac joint. So intermittent sharp twinges at right SIJ. Frequently stiff when moving from a sustained position. Okay, so stiff after sustained positions. Aggravating factors: left side flexion. We definitely want to put that here. That will be an impairment. You can also abbreviate this as side bending, SB, side bending. And then prolonged sitting and standing. And that's going to go under our activity limitations. However, we know that sitting is involved in horseback riding, and standing is most likely involved in her job as a stable hand, because I would doubt that she's sitting around doing that activity. So she's standing and walking around and cleaning horses and cleaning stalls and taking care of the horses. So that most likely involves a lot of standing activity. Mechanism of injury. Relieving factors: lying on right side or supine and heat. And this is what we call the FYI category. This gives us a little bit of information about what relieves her so that we might be able to choose exercises in her exercise program that are beneficial for her to help her relieve her pain if she gets into some pain during an exercise program. Under mechanism of injury, we see that she fell off of a horse while jumping. She landed on her right side 1 week ago. Her right boot got caught in the stirrup and she was dragged about 10 meters. So significant injury there. Previous injury: she has fallen off a horse before. She has a previous right anterior shoulder dislocation, and that happened in 1998 and 2001 and 2003. So that's a significant issue that we need to be aware of. She had a Bankart repair to the right shoulder in 2003. We don't know if that shoulder is affected at all. We'll see in the objective findings here. Under general health, she's a social drinker and she smokes 10 cigarettes a day. Now you might put this on the problem list if she is, if you're trying to counsel her to stop smoking, or if you wanted to refer her to a smoking cessation program. Otherwise, it's not going to affect the exercises that we give her, so we wouldn't necessarily have to put it on the problem list. Recreational activities, she competes in equestrian events, including jumping and dressage. She likes hiking and 10-pin bowling. So we know that she is unable to ride a horse. We've already seen that. And she has trouble with walking, so she's probably decreased in her ability to hike. And then under 10-pin bowling, she's probably unable to do that because she can't handle prolonged standing, and she also has acute low back pain with standing. So increased bowling. And we know that all her recreational activities are affected, and also her job is affected. So this particular injury has a huge impact to this woman's quality of life. All right. So then we go into objective findings. We see that her posture is sway posture with an anterior pelvic tilt. So there are a couple of types of sway back posture. One is with an anterior pelvic tilt, and that's what she's demonstrating here. Another type of sway back posture is more with a posterior pelvic tilt, so that the pelvis is sent forward. We're hanging a little bit on the Y ligaments, and the lumbar spine is in extension. So in both sway postures, the lumbar spine is in too much extension, but the pelvis is in different positions. So under this type of sway back posture with a posterior tilted pelvis, we see that the lumbar spine is in extension, the pelvis is forward. And the other type of sway back posture with the anterior pelvic tilt, the lumbar spine is also in extension, but the pelvis is in more of an anterior tilt. So what we want is to improve her posture. So we want to decrease the anterior pelvic tilt. And then we see that she has an increased thoracic kyphosis with rounded shoulders. So we want to decrease thoracic kyphosis. And we also want to decrease round shoulders. Her left iliac crest is higher than her right. So I'm going to come up here and put that. Left iliac crest higher than right. Okay, next piece of information. Observations in standing. She has a slightly decreased weight bearing through the right lower extremity. So that's in standing, so we're going to put that here with our activity limitations. So decreased weight bearing right lower extremity. All right. She moves slowly from sit to stand. So we talked about stiffness with sit to stand, but it's also slow. That's another piece of information we can add to the grid. She has fixing and thoracolumbar extension. Okay, so we'll put that here. Fixing TL extension. Active range of motion, lumbar spine. Spine flexion, 75%. Extension, 25%. We're going to start to write these down. So active range of motion, lumbar spine, flexion, 75%, extension, 25%, side bending left is 10%, and also pain occurs with that motion. Side bending right, or side flexion right, depending on how you want to call it, is 75%. Thoracic rotation is 30% bilaterally. Okay. Straight leg raise, right, is 45 degrees, and straight leg raise left is 60 degrees. All right, strength. Right lower extremity is 4 out of 5. Left lower extremity is normal. So 4 out of 5 on right lower extremity. Under passive range of motion, we see that the thoracic spine extension and rotation are stiff. So passive range of motion, T-spine extension and rotation is stiff. Special test under alignment of the left ASIS, pubic tubercle and ischial tuberosity are all 2 centimeters higher than right. So here we have left iliac crest is higher than right, but we also see that the whole pelvis, not just the iliac crest, is higher than right. Forward flexion test is hypermobile on the right. Okay, so that means that under the sacroiliac, on the sacroiliac joint, if you're palpating the PSIS, the left side will move first prior to the right, which indicates that the right is hypermobile. And that's how that test is interpreted. All right, so right SI hypermobile. All right, neurological system is intact. Under clinical impression, we see that she's had an acute traumatic downslip of the right ilium on the sacrum with hypomobility of the thoracic cage. So this right hypermobility makes sense, that she was pulled from the horse, from her right leg, and then the height of the left iliac crest is because the left iliac crest is higher than the right. It's because of the right ilium being pulled downward, the right whole pelvis being pulled downward. Okay, so now what we want to do is turn those problems into goals. So we see that we have a lot of problems in our impairments section, which all of these go with the impairments. Okay. And that's a big part of our grid there. Okay, so we have right constant lumbosacral pain. We want to decrease lumbar spine pain or lumbosacral pain. And she's 28 years old. This is a traumatic injury, so I feel like we can get this down to a 0. We want to decrease the radiation or the radicular pain of the right buttock. We want to centralize that pain. We want to decrease the sharp twinges in the SI joint. We want to improve stiffness with sustained postures. And so we'll be talking about this with the seated exercises. So we could say decreased stiffness. And sustained postures. And that's probably going to improve as we get her moving more and to normalize her pelvic alignment. Left side flexion is painful, so decrease pain with left side bending. We want to improve posture, mainly that anterior pelvic tilt, thoracic kyphosis, and round shoulders. So we'll say improve posture here, addressing all of those things. And then we go up to the right SI, hypermobile pelvis. We want to normalize alignment of pelvis. So these two here, the right SI hypermobile and the left iliac crest higher than right, will be addressed by normalizing the alignment of the pelvis using any manual therapy techniques or muscle energy techniques that you choose to use in your scope of practice. We have fixing in the thoracolumbar extension, so we want to improve mobility of thoracolumbar region. And we also want to increase mobility of the lumbar spine, active range of motion here, and we'd also want to improve thoracic rotation. We want that straight leg raise on right and left. I want to see that improve to 90 degrees bilaterally without pain. She's 28 years old. She's very active. She should be able to lift the leg to 90 degrees without pain. And then strength, we want normal strength of bilateral lower extremities. All right. So we've already talked about passive range of motion, thoracic spine extension and rotation. So we also want to improve mobility of extension as well. So we can just start adding in things as we go. All right, so the goals for acute low back pain with sitting, standing, and walking. We want her to basically have zero pain with sitting, standing, and walking. And we want sit to stand. Again, zero pain and within normal limits as far as mechanically and speed-wise. So we want it to be normal speed going from sit to stand. We also want her to be able to sit and stand for at least 1 hour without pain. And then with horseback riding, we want her to be able to ride a horse pain-free. With good mechanical alignment and technique. We want her to be able to hike pain-free. And we want her to be able to bowl pain-free. So obviously we're not going to go through a litany of all of the problems that she has. We're going to highlight 2 or 3 problems and tell her what's going on and what we found in our assessment, so that we're basically trying to turn those problems into positive statements. So we say things like, we're going to work on normalizing your pelvic alignment through some manual therapy or physical therapy techniques. We're going to start to get you moving. After we get that normal alignment, we're going to stabilize the pelvis, get the rest of your spine moving normally, decreasing the stiffness that you're feeling in your spine. And then we're going to help you get back to doing the activities that you love, like working as a stable hand, competing in your equestrian events, by improving your tolerance in sitting and standing, improving your posture in sitting and standing, and helping you get back to doing the things that you love doing, improve your quality of life. So we might summarize it in just 3 or 4 sentences and then move forward from there. Do you have any questions about your program? Is there anything that we missed that I need to address? Now we go on to treatment. We keep our healthcare practitioner hat on here as we work on the treatment techniques. And then once we move into the Pilates program, that's when we'll start looking at specific Pilates exercises here. We're just thinking of concepts, treatment techniques, and exercise categories, like this is our outline of our program. And then we'll fill in the details with our exercise programs later. All right, so we want to decrease lumbosacral pain to within normal limits. And we also want to decrease the radicular pain into the right buttock and decrease the right SI pain. I think that these 3 goals are going to be achieved simultaneously. So what we'll be doing is we'll be doing pelvic girdle mobilization. We might use strain counter strain. We might use muscle energy techniques. We might use myofascial release. So it depends on what your method is or what your skill set is as to what treatment technique you use to normalize the pelvic alignment. We're also going to try to decrease stiffness with sustained postures. So this means that we're going to first normalize the alignment of the pelvis. That should be our first goal here. Then we're going to help her stabilize the normal pelvic alignment. So I think it's important to note that a lot of times Pilates programs don't help people that have pelvic asymmetries or pelvic torsions or things like what she is experiencing. And they often get worse with a Pilates program. If you stabilize that asymmetrical pelvic alignment or that downslip pelvis, then you're actually, if you're doing strengthening or core control exercises, you're actually strengthening the faulty alignment. So what we want to do is normalize the alignment first, then stabilize the normal pelvic alignment, and that's going to help probably with decreasing stiffness in these postures. Then we start to work on improving her posture. So we'll do postural re-education, but we don't want to normalize her posture or give her the optimal postural alignment on a crooked pelvis. So we want to make sure we align that pelvis first. We've got here also normalize the alignment of the pelvis, which is going to be here. We're going to deal with that. We're going to decrease the pain with less side bending. That's also probably going to make a difference when we normalize the pelvis alignment. We're going to improve mobility of the thoracic and the lumbar region. So this was the fixing that we were talking about. So we might want to do spine mobilization actively or passively. So active or passive, which means we're mobilizing the spine. We might use mobilization techniques, or we might use movement actively so that she's moving the spine to help her with improving that mobility of the thoracolumbar region. We want to improve mobility of the whole lumbar spine as well. So we had different ranges of motion here, especially in extension we're limited, especially side bending left we're limited. So we're going to also do spine mobilization of the spine actively and passively. We're also going to improve thoracic rotation and extension. So we certainly want to do some thoracic mobility. And especially thoracic extension exercises. So this is just helping us understand what exercises we need to pick when we go into our programs. We want to improve her straight leg raise to a 90 degrees. So certainly want to do hip disassociation exercises. And core control type exercises with that. That's going to be helpful. And then we want to improve the strength of both lower extremities. So we'll want to do bilateral lower extremity strength exercises, most likely in a weight-bearing position. We want to improve her pain or decrease her pain in sitting, standing, and walking. So this is when we go into our functional re-education category. So we're going to do functional re-education, progressing from a foreign environment to a familiar environment. So this means that we'll be doing sit-to-stand activities in a supine position first, and then progressing upright, even into quadruped or kneeling, and then up to full standing. We might be doing some gait training with the walking. We'll need to do that as far as to get her gait back to normal. We're going to be practicing sit to stand with some biomechanical counseling. So some biomechanical counseling is going to be important for helping her not to perturb the lesion. Okay. And we also want her to be able to sit or stand at least 1 hour without pain. And I like to call this postural endurance. So we might want to keep her in postures for longer periods of time, so that the client understands that posture is not just about hanging on your bones. It's a little bit of work to stay upright for long periods of time. And lastly, we want to re-educate her in riding. So we want to do simulation activities. So I like to call this recreational simulation. So that we're doing horseback riding simulation. We're we would have her do some hiking, climbing upstairs, or watching her hike up a hill if we go with her, or have her film herself hiking and see how her posture is and her gait. And then we might watch her bowling or try to simulate bowling. So we definitely want to simulate those activities as much as possible in the studio so that we can see if she can carry over all of these skills and these concepts that we've been trying to teach her in the studio into her activities of choice, recreational activities or her work activities. So what stage of rehabilitation is she? So this would definitely be a stage 1. We want to get her stable. We want to normalize her alignment of her pelvis and get that pelvis stabilized so that she's not hypermobile on that one side in the pelvis. So we're going to call this a stage 1 and treat it accordingly with stabilization exercises, especially directed toward the pelvis. And then we'll get her into mobilization exercises as she tolerates. So now we'll go on to the level 1, 2, and 3, or introductory, intermediate, and advanced Pilates program that would be appropriate for this client. Okay, now let's make the program for this client. We're going to start with a beginner session. Should be about 8 to 10 exercises. And you're assuming that you've done your assessment. You've also done your pelvic recheck with her to see that her pelvis is in the correct alignment. And then do any treatment that's necessary, making sure that the pelvis is in the correct alignment, treating it as necessary to get it aligned. And then starting with your stage 1 stabilization of the lesion, which will be the sacroiliac joint, and starting with the program. So what do you think would be good to start with? Yeah, that would be a great choice. You could start on the trapeze table with the parakeet. And maybe not doing the full advanced version of the parakeet, that you're just doing the footwork position of the parakeet with the springs from above, really getting the hamstrings to pull the bar down. Another exercise you could start with is footwork on the trapeze table as well. So either one of those would be a great choice. Yeah, and then moving on to the mat, doing either dead bug only, or if they're able to, you just go ahead and progress right into the femur arcs if they're able to stabilize their pelvis with one extremity still on the mat. Then going into bent knee fallout or bent knee opening. Also doing from bent knee fallout, you might move into side lying so that you're asking her to stabilize her pelvis in a different relationship to gravity. And she had pain with lying on her left side. So if she lies on her right side, she has relief of pain. So you might start her with this exercise lying on her side that gives her relief. And then moving the leg to see if she can move the leg into abduction and flexion extension in that different relationship to gravity. All right, and then we move into possibly into either quadruped or prone hip extension. So what I often do with somebody that has pelvic instability is I will try them in a quadruped position, see how they do with aligning their body. Use the dowel, see if they can shift their weight back and forth, maybe raise the arm and leg. If they have a hard time finding out where they are in space or being able to organize the body, then I'll lie them prone and have them do hip extension here and maybe just the hip extension part. You can do the pre-swimming here and just do the hip extension part because the shoulders are not able to flex fully. So she's going to have a modification if she adds the shoulder flexion to that exercise. So you might just do the hip extension part with the first session. Then you might move on to the reformer and do the supine arm series. So you've taught her the bent knee fallout and the dead bug so that she may have better control of her legs in that tabletop position. And then going on to hold that position and move the arms. Yeah, then going on to the chest lift. That would be great to have her do the chest lift so that she can learn how to connect her head to her body, keep the pelvis stable as she flexes through the thoracic spine. I would be looking especially at that thoracolumbar junction to see what it's doing during the chest lift, because she was fixating an extension there. Then going on to the spine corrector and doing the supine stretch. Then you can modify the shoulder position if you need to, with the hands behind the head. And having her, since you've just taught her how to do the chest lift, connecting the head to the body, then having her go into the supine stretch would be a great option to get some thoracic extension, but still stabilizing the lesion site. And then on the chair, we might think about doing standing leg pumps. Now I might bring the pedal down as far as possible so that she doesn't have a lot of range of motion to go through there, and really looking at, can she put weight on that standing leg that's a little bit painful, by doing all the treatment that you've done and the neuromuscular reeducation. And then if that doesn't work, then you might try to do something like, on the trapeze table, spring-assisted squats. Now, a lot of students feel like the spring-assisted squats are very advanced, but I often use this exercise with my older adults, with putting a chair behind the table, using blue or heavier springs in order to give them a lot of assistance with sitting to standing, and then having them just practice sit to stand with that assistance of the springs. So it can be a really great lower level exercise. You don't have to do all the fancy variations with that if they're not ready for it. Just put the chair behind the table. All right, so now we've got an exercise on each of the pieces of apparatus. We have some mat exercises that they might work on at home. We also have a good flow of the session, generally starting in supine, having our spine mobility exercises in the middle of the session, and ending with standing to get them ready for going out in life. Now let's move on to the intermediate program. This is where we're going to be doing more assisted mobilization, and we're going to have 10 to 12 exercises in this program. Okay, so what might we start with here? Yeah, footwork. So on the reformer, absolutely, yes, increasing the speed gradually. So I would think about varying the tempo and maybe looking at trying to help her progress that sit to stand to a bit faster. Yeah, we could do either feet in the straps, and then even progressing into, maybe partial short spine for mobilization of the spine. But I wouldn't go into that as the second exercise. So either feet in the straps or bridging might be a nice choice on the reformer here. Yeah, then you progress your supine arm arcs to the supine abdominal series. You've done chest lift to prepare that head from coming forward for coming forward, and now you can do the challenging core control exercise with the legs extending and the head lifting. All right. Now, what might we move on to from here? Sure, now it's time to start to do a seated exercise or a seated roll down, so that the reformer provides some movement of the pelvis underneath the body, so that you're basically asking the client to move the reformer with the pelvis. And let's start. So we'll add, let's see. Yeah, we could do seated roll down on the reformer. So I really like this exercise as an assistance for spinal mobilization. the carriage moving underneath helps to facilitate the pelvis, initiating the movement. So keeping the length of the spine, curling the pelvis underneath, having the client think of moving the reformer with the pelvic curl is a really nice way to help mobilize the lumbar spine. And then you can add in the arm variations and the rotation with that as well. But I like that one for an assisted roll down and assisted mobilization of the spine. So yeah, then we could go into quadruped. And if the client is ready, going into reverse abdominals. And so we progress that quadruped position, we get the upper extremity weight bearing and core control. Moving on to the trapeze table. Yeah, we might think about doing either the mermaid or the seated arm pull down, going into mermaid, or push through with circumduction. You've got the assistance holding onto the bar, you've got the ability to get that assistance to go into a side bend or a rotation with that exercise. And you don't necessarily have to go all the way into the circumduction. You can break it down and progress it gradually. Because you want to imagine that you've had 6 weeks in which to progress all of these exercises with all of their variations. And then you're going to progress all of these exercises with all of their variations before you go into the week 12 or the advanced program. So yeah, we could just do a mat exercise. So we have the mat side to side. Yeah, or book opening. Either one of those would be great. Starting to incorporate the rotation. And then pelvic clock certainly could be done. And then going to the ladder barrel, yeah. So we could go to the ladder barrel and we could do the modified side bend because we're still in the assistance with mobilization phase. So the modified lateral flexion. It's where they're standing in the barrel, bending over the barrel, really working on mobility there, using the barrel for assisting them with the mobilization before we go fully into the short box series. Yeah, bridging on the ladder barrel would be a great choice for her. Because here you get the thoracic extension and the lumbar flexion. You're actually able to work with her on equal weight bearing bilaterally. You can watch the pelvis. She's able to see the pelvis as well with the ladder rungs being a little bit higher than her torso. And that's just a fabulous exercise for pelvic stabilization as well, especially with the single leg version. So you could try the single leg versions to see how she's doing with pelvic stability. Yeah, so it's time to go onto the chair. We go onto the chair and do hamstring 1. That would be a great progression to doing a full roll down or the more advanced exercises like on the ladder barrel, the back to forward bend. This would be a great preparation for those. And then forward lunge, sure. So forward lunge. Certainly a great progression from standing leg pumps to forward lunge. We could increase the spring tension. We could make sure that the pedal's all the way up close to the platform so that she doesn't have a long stride to take there. She might be able to block the pedal from below so that she doesn't have such a large range of motion at first. You can certainly find lots of ways to modify this so that it's safe for her. Now let's move on to the advanced level, dynamic stabilization or mobilization. We're going to have about 12 to 15 exercises here and trying to incorporate all of the exercises that are going to get her back to riding horse. So you mentioned earlier that we wanted to start maybe with bridging. And it could be bridging on the mat, the reformer. I wouldn't necessarily start with bridging on the ladder barrel, but bridging on the mat or the reformer might be a nice place to start. And then we talked about bringing that to maybe doing a leg circle, starting with a bent knee, increasing the mobility to a mat leg circle. All right. And then what will we move to? So we've written down our wish list over here of exercises that we would like to incorporate. We talked about incorporating hip extension, which would be a great challenging exercise on the trapeze table. We talked about incorporating leg circles on the spine corrector, or the leg series on the spine corrector. We talked about inverted V on the reformer, side lift on the mat, standing splits, or the side splits on the reformer. Okay. Okay. So we can maybe start with inverted V, and we could also maybe do either long stretch or jackrabbit, something like that. That there's a couple of different exercises in that position. Okay, and then what? Another challenging exercise. What about doing something to make sure that she has good thoracic extension? Maybe something like, I would maybe move up here and do prone pulling straps. Maybe pulling straps on the long box, and then progressing to inverted V. You could do things like teaser and backstroke. That would be great for her. Let's regroup here. Let's move inverted V. We can just renumber. That's what I like to do a lot of times, is don't put numbers and then I go back and renumber with what makes sense. So we've talked about bridging, leg circles, and then pulling straps, backstroke and teaser. So I would do backstroke and teaser next. And they don't have to both be taught. You can do one or the other, but usually people like to do 2 or 3 reps of each one and they're done, right? So 3 backstroke and teaser, and then 4 pulling straps. Yeah, on the reformer, because you've done the supine abdominal series, so now you're going to progress the supine abdominal series to either short box, like you mentioned. You could do short box, backstroke and teaser. Short box might be nice because you're incorporating a lot of different motions. So I like short box here too. You had mentioned that earlier. And then I would do number 5 as pulling straps, and then 6 would be inverted V, and 7 might be long stretch or jackrabbit. And then we could go ahead and stay on the reformer and do side splits. I'd like to see her be able to do a light spring with side splits to facilitate pelvic control. All right, so let's see, what have we done here? Side splits.
We talked about doing the leg series on spine corrector.
Yeah, so you could go to the spine corrector and do leg series. Spine corrector. And they're all reformer. All right. Yeah, the leg series on the spine corrector I like because they can feel where their pelvis is on the top. They can see if their legs are going in out of alignment or in rotation or funny directions. They can actually almost see the pelvis, and the pelvis is really placed on top of the spine corrector. So that's a really nice series to be able to be sure that a person has really good pelvic stability as their legs swing around in space. Yeah. Okay, so we got our leg series on the spine corrector. Now, we've got some other wish list exercises that we made a list of. Hip extension on the trapeze table, side lift on the mat, horseback on the ladder barrel, side lunge, and seated leg pumps on the chair. So what would you like to move to next? I think it might be nice to move to the trapeze table and do hip extension. So let's do hip extension on the trapeze table. And anything else on the trapeze table? We could just stay on the trapeze table and do the side lift mat exercise. That's pretty much a multi-purpose exercise. It does shoulder stability. It works on shoulder stability. It also works on core control. It works on hip abduction and ankle stability as well. I do want to see something that has arms overhead. So yeah, full shoulder flexion to make sure she's achieved that. Want to have full shoulder flexion there so we get that shoulder mobility. And another exercise for shoulder might be the supine stretch, eventually into rollover. She's 28 years old, and you've been a great therapist, and she's achieving all her goals. So it might be nice to even have that in there as well. Okay, so we've got side lift on the mat, and then we could go into horseback on the ladder barrel. And you can even ask her to bring her saddle to the clinic and let her try the saddle, being in the saddle and really seeing what position she's in and with the relationship of her feet to her pelvis in the saddle. And then going on to the chair, doing seated leg pumps, maybe with seated on a rotating disc or a wobble board. I love doing seated leg bumps on a wobble board. It's a really great unstable surface. Yeah, it's and everyone gets on there and they laugh. Yeah. Immediately. It's so funny. If I want to cheer somebody up for the day, I put them on either the air-filled disc or the yeah, because it's that unstable surface. Yeah, really fun. All right. So, because seated leg pump seems like such a basic exercise, but in this respect, we're really putting that unstable surface underneath and maybe doing it in abduction, so that she's got one leg on the outside of the chair and the other leg on the top. Yeah. Okay. And then maybe into the side lunge. Yes. Love that. For finishing up the program with the side lunge. So you're really getting into that hip abduction there. Okay, so you do have time if you wanted to put in, during the time that she's on the ladder barrel, you could put in the rollover for that full shoulder flexion stretch, going, and you could have even had supine stretch in here on the ladder barrel. You had it here on the spine corrector, but you could do ladder barrel supine stretch so that she gets the shoulder mobilization as well. Another good shoulder exercise for her, to help improve her external rotation might be this kneeling or seated arm series on the reformer. Or off the edge of the trapeze table, the standing on floor arm work. Yeah, like the hug a tree, the salute, the twist, the butterfly. The butterfly would be good. So that series could also be a good choice as well in here for her. You can't pick everything, so you're trying to pick things that are going to help her achieve the goals that we've set for her, and making sure that you've got a good flow to the session, you've used all the apparatus each time, and that you've got a good progression between the sessions each week. That you wouldn't teach something like chest lift 100 before you've taught chest lift, or certainly not doing backstroke or short box series before you've taught them how to do the chest lift. Okay? All right, good.